So thank you for the invitation to be part of this fantastic series of seminars. I've seen a couple so far, and they look wonderful. So hopefully I can deliver the goods somewhat as well. Thanks for joining in, and hopefully I can take you through I guess my vision of where current aspects of Raman spectroscopy sit within the likelihood of being able to deliver something for routine clinical diagnostics. And also where the future lies in this kind of field. So we've heard a lot of great speakers in this area. This is very specifically about the use of vibrational spectroscopy, so I guess others haven't talked about that yet. And I'm coming from a clinical background, a physicist who has worked in the NHS for 20 years, so I have a lot of access and engagement with clinicians as I've worked through this work. So it's always been, all the work that we've done has always been driven by the clinical needs. So I'm going to talk about some of the clinical needs, and why optical techniques can really enhance the diagnosis of disease. Now, cancers are a significant disease, as we know. Many of us will get them in our lifetime. And if we wait till we're symptomatic, there's usually a problem in the sense that symptomatic patients usually have advanced cancer. Advanced cancers are much harder to treat and end up being more likely to kill the individual. So what we're trying to do is find cancer at a much earlier stage. Let me just turn on this laser pointer. So what we're trying to do is find cancers when they're very small surface cellular disease. Now, this is incredibly difficult in many organs, because how are you going to find these? It's very, very tricky indeed. So sometimes what you need is a group of patients, a group of individuals who are at greater risk of developing disease. And one example here is Barrett's esophagus. This is Hugh Barr, Professor Hugh Barr, who's a GI surgeon at Gloucestershire Hospitals, and he's really motivated by Barrett's esophagus, which is a pre-cancerous step in the lining of the esophagus, which drives the process or raises the risk of getting cancer by around about 100 times in the esophagus. The problem is, to make that diagnosis, still, even for these asymptomatic patients with at high risk, you still have to go down and use putting an endoscope inside, a telescope inside the esophagus, and try and find disease, which is invisible if it's early cellular disease. This requires a whole lot of biopsies to be taken, lots of bits of tissue being torn out of the lining of the esophagus, generating all these biopsy pots that the NHS and pathologists have to observe, and then they have to look at those and try and understand what's going on. As you'll note as well, if there's early cellular disease here, or here, or here, we will have missed it. So there needs to be an improvement in this process. So the second problem is, so the identification, the finding is hard for a pathologist, for a surgeon or an endoscopist. When a pathologist has these samples, they then also have issues with identifying the location, the pathology within that sample. So if you're looking at advanced cancer, it's reasonably easy. If you're looking at normal tissue, it's reasonably easy. The question is, at what stage are they able to make a really reliable diagnosis? Now, if you look at low-grade dysplasia, where we'd like to make the most simple treatment, maybe you could use a laser to burn away the surface. You could use photodynamic therapy. You can use all sorts of different approaches to treat just the surface of the esophagus. We ideally want to get an accurate measure of low-grade dysplasia. Now, these are 6 samples shown identified by one leading pathologist, and these are what other pathologists said these samples were. So there was only one who's close to saying what the other person said for low-grade dysplasia all the way across the board, apart from here. But actually, the 4 pathologists only actually agree on B3 and show that's indefinite for dysplasia, meaning they can't really make a decision. It's too tricky. So the next issue is that with some of the work we've done, originally we took 150 biopsy samples, and we got pathologists. We realized we needed a consensus pathology panel to make decisions on the real gold standard that we're then going to use for training our diagnostic models with. And what we were able to see is that actually, as we worked our way through the pathologists, we got majority of opinion and then consensus of opinion. You see, we lose more and more samples. And by the end of it, we're mostly keeping the green samples, which are normal tissue, and the black samples, which are advanced cancer. And the rest of the in-betweens are disappearing because there's no consensus of opinion. So what we need is a better way of providing an accurate measure of disease, ideally finding that disease in real time in the esophagus and providing a risk rating based on basically a light measurements that we are aiming to do inside the esophagus. And I'll explain how we do that in the next few slides. So what we want to do is identify those with high risk, potentially treat. Low risk, we might take a biopsy, and the rest we would not. So what we, in our group and a number of others around the world in recent times, have started using a technique called Raman spectroscopy. Now this is utilizing the inelastic scattering of laser light, and you can use any wavelength, but we use near infrared, so this is not an ideal diagram. We use near infrareds to minimize the fluorescence from the tissue, and we look at the inelastic scattering of energy from the laser line. So we end up having a spectrum that's made up of a number of peaks. And these peaks relate specifically to the molecular vibrational modes, the amount of energy required to induce a molecular vibration in the molecules present in the cells and tissues of interest. And this gives us a whole biomolecular fingerprint that we can use to interpret and understand what is going on. And we can use that as a fingerprint to identify, here's 4 different prostate cancer cell lines. We can separate those out by their phenotype because we're measuring a whole range of different biomolecules. We can show the different types of tissue and pathologies, and I'll come back to this later. And we can use that information also to reconstruct images by having individual points. Using a microscope, we can scan that laser across the sample, or the sample through the laser beam, and we can create biochemical maps of the tissue and use that for spectral histopathology. So what I should also highlight is that shift in energy. So if we look at Rayleigh scattering, we have a laser illumination. The light is scattered off with no change in energy. This is the most common interaction we're likely to see in cells and tissues. If we have the shift I was showing you, where you basically give up some energy to the molecule, it's a Stokes interaction. But if a molecule's already vibrating, because of thermal interactions, basically we can take some energy from the molecule, and that will give some energy to the photon, and that enables us to basically have almost a symmetrical spectrum, apart from the fact that the anti-Stokes is much less likely to happen, and I'll come back to that later on. So what we do is use the Stokes side of the spectrum, and that's the part that gives us the most signal and tells us a lot about the molecular fingerprint of the cells and tissues. Okay, so the early work in the esophagus involved us using a microscope to try and understand the signatures that we would get from the different pathology, the full range of pathology groups within the esophagus. And as you can see, the fingerprint is remarkably, for each of these different pathologies, is a mean spectra for each of those pathologies. And you'll see they're actually really similar. Forget the vertical offset. There's a lot of different squiggles in here that represent amino acids, protein backbones, lipids, nucleic acids, and carbohydrates. And all of those things all add up to tell us information about what's going on in the cells and tissues of interest. If we use machine learning approaches or multivariate statistical analysis, we can separate out these different groupings. This is a 3-group model which we might use for biopsy targeting, and each of these dots is a spectrum we've measured, and you can see we can separate this out by pathology. Now, this was only possible when we used the consensus panel opinion of our pathologists. If we broke it down into all the individual groups, you'll see here the consensus panel enabled us to also separate out all the different pathology groups pretty well, with some crossover in the areas where there is a biochemical continuum of disease, but also where there is a potential discrepancy in the pathologist. Now, if we look at models that are created with the majority pathology opinion, you'll see there's much more crossover. So we want to try and avoid this. So we want to basically improve on our gold standard before we use any form of training for novel techniques such as Raman spectroscopy or other optical techniques or any form of new diagnostics. You've got to make sure you understand the gold standard and do the best you can to maximize its discriminating power. Okay, so once we got ourselves a good understanding of what Raman spectroscopy could do under a microscope, we then effectively compromised the system to enable us to insert it down inside an endoscope. Now, the optics to do that involve getting less efficient light collection, and we're obviously illuminating the sample potentially with less intensity of laser light to ensure we don't cause any damage to the surface of the tissue. So in this regard, we created a confocal, miniature confocal Raman probe, working in collaboration with the teams at Gloucestershire Hospitals, where I was working at the time, and John Day in Bristol. Alex is our postdoc on this project at the moment. And what we were able to do is demonstrate that we could still measure signals that were had sufficient signal to noise and able to give us enough signal information to use this to attempt to discriminate disease in 1 to 2 seconds for individual point measurements. Now, we developed this confocal probe to ensure that we only measured signal from the surface of the esophagus rather than looking at signals from deep. If you're using near infrared light, it travels quite a long way in tissue, and you can potentially collect signals from much deeper, which you may not want. This is apparent when the team in Utrecht, who I was collaborating with, were looking at bladder cancer. So we did some work initially under our microscope systems, and you can see these are the fingerprints of different pathologies that we would see in the bladder under a microscope. So we're just looking at that very much the surface of the tissues of interest. But in a non-confocal probe in vivo, you'll see there's a remarkably different spectrum. And what this is actually picking up is the fat that surrounds the outside of the bladder. So you can see this is superimposed on the spectrum that we see on the right, because the light is traveling all the way through the bladder wall, which is quite thin, and picking up signal from behind. So it's really important to use confocal probes to ensure you measure the appropriate surface depth of interest. Okay, so next point. So we used our confocal probe in the laboratory on ex vivo samples to, in 1 second, to demonstrate that we were able to discriminate the pathologies of interest to enable to set us up for an in vivo study. In this process, we were able to again use multivariate analysis, which is principal component fed linear discriminant analysis, which basically compresses the data, identifies the key spectral features, and provides particular weights for those particular spectral features, and we can then create a diagnostic model. So when we get a new spectrum, we can feed it into that model and see where it sits in this decision space. And this is what we see for our pathology groups. We've got a reasonable separation of sensitivity and specificity for a number of different pathologies, the real key being this one here, but it isn't perfect. So the question is this good enough? And this is an important question that always comes up when you're considering a new diagnostic technique. Now, if you don't know what the current performance is, if the current gold standard, which is very difficult because obviously that's supposed to be in theory 100% correct, it makes life quite difficult. So what we demonstrated, what was quite important for us when we went for funding from the NIHR for the next round to take this forward for in vivo study, we recognized that this wasn't a perfect result, but it was a good result. And so what we wanted to do is use kappa statistics to enable us to consider how that performs. And kappa statistics are effectively, at 0, it's like tossing a coin or chance agreement. And at 1, it's absolutely perfect agreement. And this is what, for each of the groupings, so if high and low risk, picking up high-grade dysplasia, which is really important, we might offer somebody an esophagectomy, or picking up low-grade dysplasia, where we might offer some more mild treatments or monitor the patient very carefully. You can see we've got reasonable agreement in kappa statistics terms, but not perfect. And this is one of the criticisms from some of the reviewers. But when you put what a pathologist can generally do against this gold standard consensus opinion that we have, you know that actually as we work our way across, whether more and more discrepancies happen from pathology, relatively, the Raman probe technique is more relatively effective than maybe a pathologist is, because particularly with low-grade dysplasia, where there's these discrepancies, it can often be even chance agreement at 0 or less for picking up low-grade dysplasia. So some of these techniques could be very powerful. So anyway, we and many others around the world have demonstrated that Raman and its complement infrared spectroscopy has been able to identify disease in a huge range of tissues around the body. There's very few failures in this regard because there are quite distinct changes that are possible. There is no magic cancer peak, but if you look at the full fingerprint, there is a lot of information there that tells you about the subtle changes of disease processes. So Raman spectroscopy has been demonstrated to be a diagnostic platform technology. But why isn't it already being used? This is the question that gets asked. So we have a molecular fingerprint of disease, It's rapid and non-destructive. It is reproducible between system centers and users, provided you know what you're doing and you optimize and you develop the appropriate calibration and transfer standards. You can exceed the performance of independent pathologists, particularly if you train your models with expert consensus opinion. And we've also demonstrated in some studies prognosis may be possible. And I think this is the real underpinning future of these kind of techniques, which I'll get to later, is the fact that because we're looking at the molecular constituents of the cells and tissues, it's likely we will see the prognostic, we will understand what's happening with the disease earlier than a pathologist who's looking at a structural change in the tissue, and a radiologist who's looking at a significant structural change in the tissue. Okay, I'm not going to talk anymore about where we get the spectral histopathology side of things. So this is a very busy slide, but it's trying to highlight there's a huge amount of work going on in this area, where people are exploring new techniques to provide rapid imaging, because Raman mapping is very slow, provides relatively weak signals. I should have said that at the start. So more coherent Raman approaches or infrared imaging or other approaches that are being taken. We have a contrast facility at the University of Exeter for visitors to come and do some work in this area. But the real key in the end is going to be using artificial intelligence and machine learning linked to these huge data sets of multispectral information, molecular images that are made from unstained tissue sections, which allow post-interrogation of the molecular changes that go on with disease, which is not possible with the current techniques because they require a section and a very specific stain to be applied for the pathologist to look at. So this is kind of the fusion of digital pathology with spectral approaches, and in the long run I think this is going to have a lot of power. Okay, so overall Raman diagnostics can be applied in lots of areas, from lab-based to point-of-care testing. And today I really want to focus on the point-of-care testing and getting as close to the patient as possible. So we're going to talk about where we are in this domain and what the future holds in this domain, because light-based techniques can be minimally invasive. Ideally, they provide a real-time decision that could actually allow a treatment to be performed at the same time as a diagnostic measurement. If we just look at a point-of-care testing approach where we consider during breast surgery, axillary lymph nodes are looked at to see whether there is cancer that has moved from the breast through to the axilla, which are the lymph nodes under the armpit. And that's quite an important decision because it changes the treatment regime that the patient may have. So we undertook a recruitment across a couple of hospitals in the southwest of the Midlands. We were able to demonstrate with a reasonably cheap and cheerful Raman spectrometer, with breast surgeons doing this work, that they were able to put the lymph node on top of the probe, take a quick measurement. I say real time. It was 12 seconds by 5 times for each of these samples. But this enabled them to produce signals that could quite easily distinguish between those from diseased lymph nodes that had cancer present within them and those that were benign or had no metastatic invasion. And this is really quite important because this can be done destroying it, and it can also be done very quickly, enabling the surgeon to potentially continue that therapy, continue to take out more of the lymph nodes. The performance is very similar or better than molecular assays, which were effectively demonstrated as the most important new breakthrough in this area, but they involve the destruction of the tissue. So this is very important. However, it was discovered that that it actually was unnecessary to provide an intraoperative analysis because potentially just doing radiotherapy on patients who have the sentinel lymph node with cancer within it could actually be just as effective as doing a full axillary clearance. So clinical practice has changed, even though we've generated a technique that could completely change what the previous methodology was. But now, because clinical practice has changed in most centres, this is no longer of much importance to many breast surgeons, although I'm hoping one day they will come back to this. So we have to be aware that the goalposts are moving all the time. So we may have a future way of delivering something, but if the goalposts are moving, we know we may even be not able to keep up with them, or we can deliver something that may change on a daily basis to the next thing, or on an annual basis to the next thing. Okay. But what we were able to do from that particular study was demonstrate that with lymph nodes, there's a lot of interesting information that we can measure. And if we can do that in vivo with a needle probe instead, we may be able to use that for a clinic-based diagnosis, or a way of not having surgical removal of lymph nodes to make a key decision. In the head and neck, we've been exploring lymph nodes to see if we can pick up lymphomas. And so we've basically developed a smart needle with a Raman fiber, with a fiber down the center of that needle, to illuminate the tissue, and 6 fibers also within that needle to collect the light. And that's there to enable us to take the Raman spectra that give us the fingerprint of the tissue we're looking at. And if you see these clouds here, you will see that the reactive nodes are those nodes that swell up and are unknown, and they need to be removed to see whether there's cancer present within them. But actually, if you can identify another way, you wouldn't have removed them. So all those green dots are demonstrating benign condition. All of the blue dots are demonstrating lymphomas present within those lymph nodes. The red are squamous cell carcinomas, and the black are adenocarcinomas. So you can see just from that lymph nodes, these are metastatic disease, and the lymphomas are primary cancers in the lymph nodes. So you can see just from the signatures we see in the lymph nodes, we can potentially make a real-time diagnosis. Now, this was done under a microscope. What we're trying to do is use this smart needle, get through regulatory approval, and do this in the patient in real time. Okay, so I have taken slightly longer than I expected to give the underpinning part, so I want to move on a little bit quicker. But what I will show is that we set out with a nice straight road in this. We've got Raman, it'll be fine, we'll save the day, we'll make this a diagnosis in 5 years from beginning our work. What it became is much more of something like a windy path. We took spectra from the beginning, we demonstrated the concept, and we had to keep applying for grants. Now, during this time, as a baby spectroscopist, I had to grow up and learn a great deal. And I'm now becoming very much a middle-aged or an old spectroscopist through this life cycle, and we're now getting closer and closer and closer to that end point where hopefully we're able to provide this as a routine in vivo diagnostic, but we are still not there yet. So that's the background. Are we actually there? Are we anywhere near there? What's the near future? So there are some hurdles and barriers to adoption, and Sarah Bondic last week gave a really good overview of these key issues, and so hopefully we'll go back and look at her talk. For both our endoscopic work and our smart needle work, there's a long pathway for wide adoption of these approaches. Now, we may be ambitious with the timescales we have here, and we are currently working in this domain. Okay, so we've still got some time to go. We know where we need to go, but there will be barriers along the way. Some of those about regulatory, some of those about the performance in vivo in our first-in-human studies, and some of those about funding those multi-center studies going forward. But of course, we're going to need the appropriate approval, and we're going to need acceptance by the clinical community and the NHS and other health services around the world to want to use these approaches. To enable this to be possible, we need to do things like healthy studies as well in parallel to ensure that there's actually some utility to actually doing this. If there's, just because it provides a clinical result, if it costs a huge amount of money and doesn't actually add any actual value to the clinical pathway, there is no point in ever delivering this from the health perspective. So we have done a study where we looked just at patients within Gloucestershire hospitals for a year, and using our probe approach, depending on which different costing model you use, we are still saving the hospital between 50 and 250,000 a year just for esophageal application of Raman spectroscopy. So you can clearly see there is some value, and extrapolating that to the NHS is quite significant. Okay, so there is a chance that we can do things with minimally invasive diagnostics. We're putting endoscopes inside people already. We don't need to take out biopsies potentially if we can use Raman spectroscopy to do those real-time measurements. And the smart needle may also help us, but that's not really that minimally invasive, is it? Where I'd like to go really is to shine light into people without actually sticking things in them. We want to be able to look underneath the surface. Now we can do that if we consider, by using near infrared light, that light travels a long way in tissue, as I mentioned before. If we illuminate it at a particular point and let the light scatter in lots of different directions, you realize that if you want to catch the light that's gone to a deeper surface, the further away you go from that illumination point, the more chance you have of catching photons that have traveled at those greater and greater depths. And that's apparent when you separate this. We call it spatially offset Raman spectroscopy. But basically, if you remove the offset further and further away, you will see the spectrum from this is the surface spectrum, and this is the buried Teflon or PTFE. And as you can see, as we increase the separation of the illumination collection, those peaks change to exhibit the peaks from the deeper layers. And this is with 6 millimeters of fat on top of the PTFE. So you can see it can travel. It can give you a reasonable depth of penetration. And there are a number of different ways you can use to optimize that collection, basically illuminating in the center and collecting in a ring. So you can change that offset, but it gives you more signal by collecting more and more light in the ring. Because if you just collect at a point, you don't collect much light. And the further you go away from the illumination, the less light you are able to collect. The alternative is you flip it on its head and you consider an inverse source approach where you collect in the center and you change the illumination, and that's actually a more easy way to apply. So here's an example of basically a handheld probe that enables us to measure through different depths in the skin, or potentially measuring bone, particularly in reasonably thin layers of skin with a small spatial offset. Spectra can be measured in a second or less. There's not a problem with that, and it gives you a reasonable effect. Now, there's a number of different areas where this could be applied surgically, but what we're going to do here is consider how an extreme version of that may be able to be applied for real-time diagnostics in a useful way. Now, if you think of an extreme version of spatially offset, if we put the light at one side and collect from the other, we've called transmission Raman spectroscopy. This extreme offset enables the potential measurement of light and conditions right through an organ, but obviously there's only so far you can get light penetrating. So let's think of mammographic screening. During mammography, a lady maybe of the age between 47 upwards, 47 and 70, I think, is the mammographic screening program currently, will come for an X-ray, and a radiologist will look at those X-rays that are there and identify, through most often densities relating to calcifications, to try and make a decision whether those calcifications relate to or indicate the presence of cancer, or potentially do. Now, the problem is calcifications are present in many women, particularly as they get older, and it's these smaller calcifications that indicate the potential presence of malignancy, but not certainty. So there are many women every year that have mammographic screening, around 2 million, and only about 15,000 cancers are detected that way, whereas 40,000 are detected by finding lumps. But the problem here is that of these 2 million screened, close to 100,000 women are called back for further tests and biopsies, and many of these are picked up at an early stage, which can be very useful, but we don't necessarily know which individual should be treated in a significant way or not. So what we do know is that the calcifications are often the driver for those biopsies and those further tests. And those calcifications, actually, those type 2 calcifications, which are made of calcium hydroxyapatite, are those that are found in proliferative lesions. Luckily for us, we can actually measure spectrally those calcifications. Now, here's an example of what we did in paraffin-embedded sections, where we looked at breast calcifications using infrared spectroscopy, and we were able to separate out the pathology that surrounds those calcifications. Now, that is not the future, that is the past, but it demonstrated the potential of using calcifications. And you can see, just based on the carbonate substitution we find in those calcifications, we get a progression for reducing carbonate to more advanced cancer, from benign through local cancers to invasive cancers. So that was infrared, but we want to use Raman, and using Raman, we can switch from the mid-infrared, which doesn't penetrate tissue, not very much anyway, to the to the near infrared, which does penetrate tissue, to enable us to do transmission Raman spectroscopy. Now, I'm doing this work with a big team of collaborators, as mentioned yesterday. If you collaborate, the bigger the team, the greater the range of expertise, and the more chance of delivering on some of these bigger important projects. What we were using is Raman to do something very similar to what we did in the infrared. And what we're able to demonstrate is we could separate out type 1 and type 2 initially in a pork joint by inserting them inside the pork joint. And the concept here is that we'd like to do this in the human breast. And so we're building a system and testing it to enable us to do that. And this is the full spectrum we would measure from something similar to the breast, but to maximize the signal that we get, we are basically opening up the slit in our spectrometer and using a high dispersion grating to provide us with still some spectral information that we need, but it gives us a huge amount more signal, which can make a big difference in what we're trying to do. And we're looking for the hydroxyapatite peak, which sits at 960, just here. For the presence of that, and ideally, if you noted before, I didn't explain it very well, but the position of that peak and the width of that hydroxyapatite peak changes depending on the carbonate constitution, which relates to the pathology. So what we're doing is looking around about here for that phosphate peak from the hydroxyapatite, and we're trying to see that through large volumes of tissue in transmission Raman. Now, these are all ex vivo samples taken at surgery with the aim that the patient, that we can understand what we can see and link it directly to pathology, but with the aim towards the end of the study where we will do this in vivo. Okay, so we are again on this pathway, a long way to go. We've just in the process of finalizing our results for the ex vivo feasibility, and we will then apply for regulatory approval to enable us to do the first in human. Slightly ridiculous saying here's first in man, but it seems to be the thing we say. So we would expect next year to do our first in human studies in the breast here. So the future work we're talking about is the near future. I'm talking about, can we apply all of these different techniques to help patients? It's not about the novel technology itself, it's how you apply it and how you engineer it appropriately to translate it into medicine. Now, there are a lot of other techniques where we can be slightly more advanced with our approaches, and also the understanding of the signals we obtain. One of them is looking at the prognosis. Now, as I said before, the molecular changes that accompany are an initial step in advance of disease. We have a molecular change that we're able to measure that may preclude, or I'm losing the word, which may initiate the disease process, so we can actually monitor that before it actually happens. And so we are part of a cancer research grand challenge, which is looking at ductal carcinoma in situ, which is picked up by all those calcifications that are picked up in mammographic screening, very early disease, but a lot of those patients would not need treatment if they were left and had never had it picked up, because they're older ladies and it may never become advanced disease, but it's impossible to know. And once you know there's a carcinoma in situ, you have to offer the lady a treatment, or the man, a treatment that that may well remove the breast or do other things that are quite significant. So we want to help by using the tissue that is taken up as part of the study of hundreds of patients that have, just looking at calcifications found in ductal carcinoma in situ when they first present, and then following those patients up for many years, we've got archives of tissue that will then show whether those patients developed advanced disease after that first biopsy. And we're going to use the physicochemical properties of those calcifications to link that to the prognosis and see whether we can predict disease. We're using infrared and Raman and X-ray diffraction, and all of those bits of information tell us about the calcifications and the surrounding tissue, and that can really help us understand the molecular changes that go on with disease and the likelihood of progression. Okay, step change. I'm going to move into where we could be if we are willing to consider the application of nanomedicine or nanoparticles or nanorobots. So that's not quite true, because they don't actually, these are inert, But if you consider that the signals and everything I've shown you so far are basically native to the molecular changes that are present already in our body. Now, if we apply a noble metal on with a nanoscale roughness to close to a molecule, within a few nanometers of a molecule, we get huge enhancements of signal by many, many orders of magnitude, and that can really help us understand what we're seeing. But interpreting native signals that are enhanced in that way is very, very complicated. A more simple way is to use these approaches with a label attached to the surface, in this example, gold, and that label can provide us with a really strong signal. Now, so if we can get those nanoparticles to places of interest, maybe functionalizing those nanoparticles with antibodies, we can then identify where they are and potentially what they're doing. I'm going to skip over this slide, actually, because it's really demonstrating that actually, if you can get those nanoparticles inside, by using approaches like SORS, we can read out those technologies, whether that's with a substrate, which I'm showing here, or whether that's with nanoparticles I'm showing on the right. We could potentially, instead of, this is what you would do outside the body, use a magnet maybe to get a higher signal and take a measurement, but actually you can do spatially offset or transmission Raman, and we call this CSORS. This is surface enhanced spatially offset Raman spectroscopy. And what we're able to do is demonstrate, because these Raman signals that we get from these labels are very sharp, we can actually measure those when they're all present together. We can actually multiplex the signals and we can identify their locations for probably 10 or 20 quite easily, particularly using more advanced decompositional analysis of the spectra. And so you can multiplex those signals, and you can also measure them through very significant depths of tissue. So we were able to measure in our first example here through 5 centimeters of tissue, but we have demonstrated it through much more since then. This is the very early low power prototype system. The other benefit of using nanoparticles is that you can, because you've got a significantly enhanced signal through depth, rather than relying on those native changes of a few cells somewhere in there, as long as those nanoparticles can get to the lesion or the area of interest, you can use them to tell you something else about what's going on. Okay, so one of the things we might like to do is consider what happens when you illuminate or irradiate the tumor to see what temperature it has been raised to, using something called hypothermia. You may want to actually raise that temperature for therapeutic purposes. We can actually use spatially offset Raman spectroscopy to measure the temperature of a specific chemical within a block of material. This comes back to the point of where I mentioned the Stokes anti-Stokes as before. So if we measure, this is the laser line, if we measure the Stokes and the anti-Stokes instead of just the Stokes part of the spectrum, and look at the ratio of those peaks, it will tell us, using the Boltzmann's distribution, it will tell us what temperature the tissue or the nanoparticles, whatever we're interested in, is at a particular depth that we're probing. So by changing the offset, we can probe more deeply and measure a temperature at a different depth. But because we're looking at a Raman spectrum, we can actually look at the temperature of a specific chemical species, which may also be important. So all of those things can be linked together. So if we put nanoparticles into the tissue, we can tell the temperature of the nanoparticles and the tissue separately. So what we were able to do is demonstrate that actually if you put nanoparticles into tissue, you can illuminate with a wavelength which is resonant with a particular nanoparticle structure, which allows it to heat up. You can also put nanoparticles in that are off resonant with that particular wavelength. And you can use that to measure the temperature while use the other nanoparticles to heat up the tissue. And this could be really important for photothermal therapies, enabling the future for therapeutics as well as potentially diagnostics down this route. These nanoparticle labels can also be used to measure some of the properties of the surrounding medium, such as the pH. So there's a lot of power here. So this is underpinning where we're trying to go for potentially the next generation of healthcare. This is a potential future vision, but as I said before, there's a huge way to go, not only in the basic science, but also in the consideration of whether society and healthcare is willing to consider the injection of nanoparticles into a patient in combination with forms of electromagnetic radiation to read out and maybe provide a therapeutic using this kind of approach. We're currently running a large program funded by the EPSRC called Raman Nanotheranostics. It's led by the University of Exeter and linked to the UCL School of Pharmacy, the University of Cambridge, and the Rutherford-Apton labs at SGFC. And the concept here is trying to explore whether we can develop the appropriate nanostructures to target disease and to provide us with the appropriate seesaw signals to tell us both where the disease is and the type of disease, because if we label them with a number of different labels, we can actually see the expression of disease on the surface of a lesion. We can say that whether that cancer has maybe HER2 positive, whether it's got progesterone receptors, etc. And then we can consider how we might treat that lesion and monitor in real time the temperature that we're heating that lesion to. So you can have a real-time feedback loop to enable that to be possible. And then we let those nanoparticles disappear and get excreted, and the patient goes home, we hope. So this is a vision of the future. This is what we're trying to do. But to do that, as I said, there's a lot of basic science behind it. We really do need to look at the plasmonics of the nanoparticles to ensure that we can get the appropriate signals in the near infrared, because if we're going to get light through to where we need in the body, we need to be working in the near infrared. The problem is, if we work in the near infrared, we probably have to have nanoparticles that are a little bit big by themselves for us to get them to be appropriately biocompatible. So what we're tending to do is we're exploring how we can make nanoparticles out of a lot of different smaller structures to provide the appropriate biocompatibility. We are applying then tumor beacons, which are our Raman reporter label, and then putting things like antibodies or aptamers on the surface to provide a targeting signal, which would then be applied to the tumor. As I said, this is still all future vision stuff. So we want it to localize on the surface of the tumor, but those with different signals and different antibodies, we don't want to end up on the tumor unless there's another expression of a particular condition there. So then we'll be able to identify the particular lesion at depth in the body. Clearly, a laser pointer or a barcode scanner is a metaphor, really, but in a sense, if we illuminate here, we look at where there's photons. The photons travel a long way in the body. They interact directly with these nanoparticles and provide signals that we can read out at depth. Now, whether that's in transmission or whether that's in spatially offset approaches, that's depending on the lesion of interest. But in principle, we can read out the depth of the readout. There's some work being done by Sarah Mosca at the Rutherford-Apton labs that's shown we can measure the depth and location of these nanoparticles in reasonably large volumes. We should be able to identify the tumor type, but we can also measure the temperature and the pH. And this could have a lot of value when you're thinking of other therapeutics as well as photothermal therapy. And this might add some value too. As I said, the therapy itself could be applied either with a different wavelength or turning up the laser power and looking at the temperature increase and keeping a lid on it so we don't damage normal tissue surrounding it. And then, of course, we want those nanoparticles to slowly disintegrate and be excreted appropriately without harming the patient. So this is a potential future, but it may not be the future. This is what we're working towards, and we will hopefully, by the end of our program, understand what the limitations of this kind of approach are, and also whether the patients are willing to accept this kind of approach going forward. So the team is made up of a number of leading people in each of our key areas, particularly so Julian and Francesca at Exeter, Pavel Matusek at the Rutherford-Apton labs, Ijeoma and Andreas at UCL, and Jeremy Baumberg and Oren Sherman at the University of Cambridge. So in summary, it's a big gallop through a lot of research, but in summary, I wanted you to understand that clearly there's a long way to go with some of these approaches, and there are a lot of hurdles for us to get over for full adoption. But the future really is bright for these kind of approaches, and this is just Raman spectroscopy. The whole of the seminar series is covering so many different aspects of optical techniques that can all be applied, and as a field we can go forward together and help clinicians understand how important these kind of techniques can be. we can all provide real-time, minimally invasive, objective molecular analysis, or some of us can provide molecular analysis. But some of these approaches need more advanced machine learning and AI to be applied, and potentially provide significant value in delivering on the prognosis, which we are hoping certainly will come forward from the breast calcifications, but we also believe we can do that with soft tissue in precancerous lesions in the bladder and the esophagus as well. The question is, as well, is light-mediated nanomedicine the future or a pipe dream? Let's see whether we can deliver on that. Well, I believe it's the future. We have a lot of people we've been working with, and I'd like to thank you all for listening. It's a good question. I think being ambitious and working with people who believe in you is important. So I know. So the collaboration part has been important. I know that I set out to try and do. I think it's really important to gain confidence in yourself and engage with significant players in the field at an early stage, because I know I had a lack of confidence in the early stage of my career, and I went and met with one of my heroes, Dave Delpy at UCL, who had been doing really interesting things with near-infrared light, and I wanted to see what he thought of Raman spectroscopy and whether, as a medical physicist, I should even consider going in that direction. So having advice from somebody who is in the field, but not necessarily exactly doing exactly what you want to do, can have a huge amount of value. So developing mentors, I think, is what I'm trying to say, with different backgrounds, can really add value, and you can bounce ideas off them, and I think that really helps, and it can be really important.